welcome to the Director's Desk, the podcast where we spotlight the groundbreaking work of the National Institutes of Health and the remarkable individuals driving innovation in biomedical research and public health. I'm Dr. J. Bhattacharya, the Director of the NIH, and today I am honored to be joined by Dr. Geri Donenberg, NIH Associate Director for AIDS Research. Geri, thank you for joining me today. I've been looking forward to this conversation for a while now.
That's great. Me too. Excited to be here.
Okay, so we're doing some exciting things at the NIH with HIV, and I wanted to introduce you to the audience and just so we can tell that story. But first, I'd love for folks to hear about your background, because when you told me about it, I found it so interesting.
Oh, good. Well, I'm a clinical psychologist by training, but when I left graduate school, I ended up in the Chicago area at Northwestern, and it became very clear to me that there was some challenges. Before that, I actually had, when I finished college, I went and lived in San Francisco for a year. And it was
roughly what time period?
Yeah, it was 1987.
1987. So, this is like the HIV epidemic is sort of taking off. It's very, very clear now that it is a virus that's transmitting. It's specifically among particular populations. The gay men in San Francisco were particular, but there were other populations as well, right?
Right. And I was waitressing at the time, and a lot of people around me were talking about, because I wasn't as much a part of the gay community, but I was around all these folks who were experiencing a lot of friend deaths and things like that. And in the meantime, my brother's best friend had AIDS and was slowly dying. And so it became really clear to me, I guess at that time, that I wanted to do something about that. And I wasn't quite sure, so I got my degree in clinical psychology thinking that I can do something with mental health, and there was so much suffering and so forth. And so
that period was really, I was a medical student in the early 90s, and I remember one of the sort of formative things that happened to me was I was doing a month on the wards in Stanford Hospital in the ICU, and it was filled with dying HIV patients. There was no treatment then that was effective, and so many especially young men, were coming down with this disease that looked like a death sentence.
And it was really devastating. We lost an entire generation of folks and mostly gay men at that time, but lots of women, and injection drug use was a big transmitter also of the virus. And
that's still the case, right?
It's still the case, but it's less often the case that it varies across the world what's the primary mode of transmission.
It's different in the U.S. than in the U.S. Though it's still that same kind of epidemiology we had in the 1980s is still kind of the same epidemiology, but in the rest of the world, there's some differences.
Yeah, I don't know that it's the same with injection drug use now here in the U.S. It's a lot of sex between two people, and primarily men who have sex with men, although we're seeing an increase in heterosexual activity. Just recent CDC data said 1 out of 4 transmissions were among heterosexuals, and 23% were women. Yeah. So we are seeing a difference in the shift of who's getting most, and about 18% were adolescents, 55% were less than 35 years old. So we are really, it's as you would expect with an epidemic, it's entering the broader population, which makes it so essential to continue to focus on it, right?
Yeah. Although we're going to talk about opportunities to actually maybe completely change it for the better. But we're going to get to that.
Okay.
Let's go back to your story. Late 80s.
Late 80s. It was very hard to be in San Francisco at that time. And I remember just being very sad and, and a little bit scared, because even though we were studying it, we didn't really exactly know how it was transmitted when I was there. And we sort of had ideas, and we were being told that it can't be transmitted through saliva and all these things. But I think there was just a trepidation across the board. And
of course, there was like the blood supply there was a big controversy over even just testing the blood supply.
Right. And that led to Ryan White and the whole
Yeah.
Ryan White program, which has been unbelievable and
And
so
now the blood
important.
supply is tested routinely, which
It
is
is.
great. But back then, not so much.
No, and it sort of took Ryan White and some other folks to acquire the infection to realize, oh, the blood supply could be,
Yeah.
damaged. And
But tell Ryan White's story just so folks know. Not everybody may not know.
well, I think he was a hemophiliac, and he received a blood transfusion, and he acquired HIV.
It was a child.
He
Right?
was a child. I think maybe he was 8 at the time or 9. I can't remember now. But then no one, like, he wasn't wanted back at school. Everyone was afraid to be near him. They didn't want to play with him. And his mom became an enormous advocate. And he ultimately passed away, obviously. But we now have this Ryan White program that provides, special guaranteed medical care services for people with HIV, because they fought the good fight, for many of us.
So let's fast forward in time. It's the mid 1990s, and there's a huge breakthrough of drugs that actually prevent someone who is HIV infected from developing AIDS. AIDS is the full blown manifestation, all the terrible disease illnesses that lead to people dying. HIV is the virus, and sometimes there's years between getting
10.
infected. Now you have a set of drugs available in the mid 1990s that actually stops patients who have HIV from getting AIDS.
Correct. And actually, in some cases, turns it back around. I saw people who we thought were never going to make it actually make an incredible recovery. And there are many stories of people who put their lives in order, assuming they were going to die, and quit their jobs and decided they were going to do other things for the last remaining months. And then there was this huge turnaround, and they survived. And now, of course, we see that people can live almost a completely normal lifespan with, as long as they have access to care and to treatment and to these medications that you're talking about.
Right. And I remember, again, just going back to my experience back then, I was in med school for a long time because I did this crazy path. But the same wards that had been filled with dying HIV patients in the early 90s, the mid 90s, like 1996, 97, they're empty. It was amazing.
I'm not a physician, but that was what I knew to be true. Like, and some of them got converted to be other, wards for other kinds of illnesses. And it was crazy because during the height of the epidemic, we didn't have enough space for all the people who were dying and who were in the hospital. And so you had these crazy setups with people in hallways, and then all of a sudden these places are empty. It was really a miracle.
That's what it felt like at the time.
I bet.
And so you do clinical psychology. You decide you're going to devote your life to helping people through this epidemic.
And I was working with children and adolescents, most really adolescents and families. And it just became clear that a lot of adolescents were engaging in risky sexual activity. So for me, I was like, you're putting yourself at risk by doing that. And there was what I could see were there were so many reasons why that was happening, right? Poverty, structural factors, crime. You're in these areas where, there are so many issues on the table that in some cases sexual activity was a way to earn money, if you're a sex worker, that sort of stuff. And so from my perspective, I really wanted to prevent sexually transmitted infections, of which HIV is one. But with young people, even if they get infected, you're not going to see it for 10 years, right? So at the stage that I was working at, I had to sort of try to intervene and get folks to reduce their high-risk tests, whether it was through condom use or through learning how to negotiate relationships and be assertive in their communication with their partners, express themselves. So we talked a lot about sort of how to communicate and how, what's a healthy relationship, what's not a healthy relationship. And so I was doing all of that. And I got, I was really fortunate. I got a lot of funding from NIH to do that, do that work, and did a lot of it in
You
Chicago.
became a professor to
I
do
did.
this.
So I started out at Northwestern for 5 years, and then because I was doing a lot of prevention, there was a whole group of folks doing prevention at the University of Illinois Chicago, and it was such a good fit for what the populations I wanted to work with, and so I moved over to the University of Illinois, and I went gung ho in my research program.
And so, just for the folks at home, like the research program, it's not like you're trying to sit in the lab and trying to find new drugs or something. You're trying to figure out how can you take what's there, the tools we have, and then help people who are at risk from these conditions to use those resources.
And to change behavior, right? Early on, we thought that if you just gave people the knowledge of what they had to do, they would do it. But I think we all know a lot of things influence our behavior, right? Our motivation in the moment. And so we worked a lot on behavior change. And so, but interestingly to what you say, I have done things like develop interventions, adapt interventions that already exist, because there's really good things out there. But we know that, in order to be most effective, they have to fit the population that you're working with. They have to be sort of tailored and the context. And so I did a lot of that, did a lot of testing in randomized
It's not like you're
trials.
forcing people to do this. What you're saying is like, how do you work with people so that it fits their goals? So that the kind of knowledge that you're trying to tell them about how to avoid having these deadly infections happen can fit within the goals that the people themselves have. It's not a
Right. I mean, everyone wants to survive, everyone wants to live, right? And no one wants to be unhealthy.
right.
And everyone wants to live a healthy lifestyle, or at least feel healthy. And so we could help them see that what are the strategies that you can use that will keep you healthy? And what are the triggers that get in your way? Right. And so we would have things like, let's think about the people, places, and situations that trigger you to go do drugs, to go, or maybe you're really sad and so you go and you drink because it'll make you feel better. Getting them to see that connection, and then also helping them to see that how they think about things affects how they feel and then how they behave. And if you can
Cognitive
behavioral therapy, right?
Yeah, okay.
And if you can change,
You have been paying attention, Geri.
thank you. If you change the way someone thinks about something, you can change how they feel and then how they behave. So we did a lot of that. That was my mental health kind of coming into the HIV
But then
space.
there's also folks who already have HIV. Now these drugs are available. You got to remember to take them. If there's side effects, you have to figure out. You can go to your doctor, and I mean a lot of that is also part of the sort of like the scope of what you have to do to actually address the pandemic, right?
And we think about the continuum of prevention and care, right? So first, if you got to get tested so you know your status. Then if you're negative, there's a whole bunch of things you could do to stay negative. But if you're positive, then you move in, like we got to get them linked to care. Then we got to get them to stay in care and get the medication, and we got to retain them in care. And then we want to make sure that they're taking their medication as prescribed so their viral load is suppressed. And if you think of the virus as sort of, we don't have a cure, obviously, but if you take your medication the way it's prescribed, the virus goes to sleep in your body. And then if you stop taking your medication, it wakes up and it does all its thing. And you were mentioning other illnesses like opportunistic infections. Many people at that time, it wasn't so much that the virus killed them, but when you have no immune system, you're so vulnerable to anything that comes your way. And that's what we would see a lot of people die of these opportunistic infections.
Those new drugs come out in mid-90s. Now with those new drugs and further developments of those drugs over time, it became possible to have basically almost zero virus. The whole statement, the tagline was "U equals U." What's U equals U mean?
I'm so glad you asked me that. It means undetectable, means untransmissible. That means if your viral load is so asleep you can't even detect it, then you cannot transmit the virus to another person. And of course, for years we worried about serodiscordant couples, meaning one person has HIV, the other person doesn't. And how do they negotiate that relationship, especially if they want to have children, right? And so with U equals U, we discovered, okay, if we can keep someone completely virally suppressed, they won't transmit it to their partner.
So we have a technology, if it's used right, that that someone with HIV can live a full life, and also, if they're taking the drugs appropriately, not have any risk of transmitting it to other people.
Correct.
And now, but people could still get HIV. I mean, like I think the latest stats I saw, something like 39,000 people in 2023 got HIV
in the United States.
In the United States alone, right? And of course, many, many, many more outside the United States.
Right.
This whole okay. So just if I'm going to characterize your field, it's you're applying psychology to give people tools to interact with their environment, the way they think about things, and also the technologies that are available to give them the tools to stay healthy in the face of these deadly threats.
Yes, I'd say all of that is true, but I think what's hard, and I think we have to recognize that that's for sort of someone where everything in their environment is perfect, right? And that is really hard if you're poor and you have to work 2 jobs. It might be hard to take your medication. It's stigmatizing to take the medication. People, you don't want other people to see you doing that. Or, your family may not be so supportive, so you don't want them to see you doing it. And perhaps you live in a place that's really crowded and you don't have space for yourself, or you have to decide, are you going to put food on the table or not? So you may engage in certain behaviors that are really hard, or there's tons of trauma, right, from different things. So trauma can get in the way of all this stuff. So I think, maybe at first it's a little like, well, if we just tell them to take it, and if they knew that they just could take it and be virally suppressed, everything would be okay. But I think we didn't necessarily recognize all the context factors that could interfere with that, which is why it's been so important to have new formulations, new ways of delivery, because people have to fit what they need to take to choice.
For some people, it's easy to remember to take a pill every day. Some people, it's not.
Correct.
Right? So like an injection might be better than the pill for some people. It depends on you. It depends on who you are, your life circumstance, all of that. That's like I think it has you taught me. This goes by the name of implementation science, right?
Yes.
There's a science of understanding the context of people's lives, and how it interacts with decisions that they make, and on the resources that are available. So it's not just that we have this amazing technology that can help you live a long time, even if you have HIV. It's how do you make it so that it's available, really available, and for people in the way they live, in the circumstances of the way they are, to have it happen, right?
Yes, I think that's a great summary. And we know there are health disparities, right? We know that there are people who aren't getting access to these great medications. And I do want to say NIH has invested in incredible ways to bring us to this point. We are only here because of the many investments that NIH has done. And now, and with NIH being mostly biomedical, now we get an opportunity to shift a little bit because we have these tools. Okay, let's understand what we need to do to get these to the people who need it the most.
Okay, so I want to leap forward. So, okay, we went mid-90s. We have this amazing development. They start being essentially like HIV becomes a chronic disease, a chronic condition,
as it is,
right?
Yes.
Right. Lots of folks living with HIV. U equals U means that they actually, if they're taking their meds correctly, many of them, they pose no risk to anybody.
That's true, but I will say 65% of people with HIV in the U.S. are not virally suppressed. And not necessarily because it's their fault, for whatever reason, right? Could be structural.
It's still a problem. It hasn't gone away. A few years later, there was a new technology with the name of PrEP, right? And so PrEP is for people who have not had HIV.
Right.
They take a drug, they take a pill with usually when first PrEP came out, it was like you had to take a whole bunch of pills or a few pills
Every day you had to take a pill.
every day. And if you are exposed to HIV, injection happens. It could even be like you're a doctor and you get stuck with an HIV infected needle. You have no risk of getting HIV.
Correct.
PrEP stops you from getting HIV. If you're uninfected with HIV, you take PrEP and you have no risk of getting HIV.
That is true. But it and there are different formulations of PrEP, right? So recognizing that not everyone wants to take a pill every single day.
It's easy to forget.
I mean,
I
even my
forget.
antibiotics, if I'm to 10-day course, if I forget my last day, I'm like, oh, you know.
I won't tell your doctor. Don't worry, Jerry. It's just
Thank you.
no, I mean, honestly, look, it's often difficult to remember, especially after you've gotten better, especially if it's for something where you might get it. It's not actually addressing something that you have, right? If I'm really, really sick, I'll remember to take the pill. But if I'm not that sick, in fact, I'm not sick at all, I just taking this to prevent my getting something.
And it's also hard, like, one of the things the research has struggled with is why would you take it if you're not engaged in
Risky behavior.
Yeah. So does that mean you do it on demand? Do you do it? And there's been a lot of controversy. Fortunately, there are some new formulations that say if you take it, you've got it'll protect you within 2 hours, which is a really powerful change from, it's also, PrEP is much more forgiving of men than of women. Women have to really adhere for it to protect, whereas men, it can be a little bit less stringent.
Okay, so let's focus on this. I want to now jump again forward in time to last year. All right, last year I saw in Science magazine their breakthrough of the year, science breakthrough of the year, was essentially a version of PrEP that's injectable, and if you inject it, you get one injection, and for 6 months, the FDA just approved it for this purpose.
Mm-hmm.
You have zero risk of developing HIV, even if you're exposed to it. 6 months. It might even be a year, Jerry, if I'm understanding.
Well,
right?
Yes, they're moving to that for sure. And right now,
one injection.
I know, for 6 months. It's a game changer. It can't.
So explain why that's such an important thing, because I think you've already set this groundwork for it, but just so I understand. So because you already had the pill,
right? Why do you need any?
Yeah.
Because there are so many barriers to taking a pill every day, and like we've talked about, and I think for many people who would benefit from an injection, you do it once and you don't have to think about it again. You don't have to worry about the stigma of other people seeing you, and that came out a lot at the recent International AIDS Society conference, that people really prefer it because it's not as easy to you don't forget. You go once. There is a startup period, but you can avoid the stigma of people around you looking at you taking pills and wondering what you're doing. There are some populations who are very used to taking injections for birth control. So for them, it's kind of not that hard to just have this as an injectable. And I think that it's a game changer, because what we saw with PrEP, and we didn't do very well in oral PrEP, is we didn't understand all the barriers to taking the medicine, getting the medicine, storing the medicine. We didn't anticipate that. So it was kind of a failure in many ways. There are very, relative to what we wanted to see, there are very few people on PrEP. So if people don't have to have those specific challenges, it can be a game changer.
That was my reaction too when I saw it. The drug called Lenacapavir,
yes.
Right? And the key thing that's so good about it is because it can help people potentially, depending on your life circumstances. That's the exact right way to prevent the risk of getting HIV when you are in a situation where you are going to be exposed to HIV most likely.
Well, that's a good point. And I think what happens is if people, let's say you don't anticipate something, and then you go to a bar or you meet someone and you're going to end up having sexual activity and you weren't taking PrEP, there is also a medication called PEP that you can take afterwards. And all of these are sort of part of the same class, as I understand, of medications. But, better to prevent than post. But there's post-exposure prophylaxis, there's pre-exposure prophylaxis. But if you take an injection, you don't really have to worry about it day to day. You just say, okay, I'm safe for 6 months. And now you're safe from HIV. That doesn't mean you're safe from ever sexually transmitted diseases.
One problem at a time, Geri.
Yeah.
One problem at a time. Okay, so now we have this toolkit. It seems like we can stop someone who has HIV from dying prematurely, from spreading the disease at all. We have a suite of tools that prevents people who are at high risk of being exposed to HIV from contracting HIV, even if they are exposed. To me, that looks like a toolkit that will actually help us get rid of HIV altogether if we just deploy it properly.
I think you are right on. I mean, we can't get rid of it because it's still for
It's
people
still there,
who are
yes,
with it,
but
but
the
I
risk
think
of
we
it,
can
the risk of it.
end it as a public health threat, right? We can stop it from being transmitted to others. If we can get this right, we can end the epidemic.
And now, of course, President Trump in 2019 gave a speech, I think it was the State of the Union speech, where he committed the country to ending the HIV epidemic in 10 years. Now, I remember that speech. I remember because it struck me, because I've been tracking, I've actually published on HIV once upon a time. So, it struck me as like a very ambitious goal. I mean, I was like, this is great. But it felt like at the time in 2019 that we didn't have the whole toolkit we needed to do it. Now we have the toolkit, don't we?
I think we have the toolkit. There are people who will say we will never really get it until there's a cure. But I believe we could get pretty darn close. And at the very least, we could get it so it's not a public health threat.
So why is there any reason to wait? Why don't we just do this? Why don't we just really commit to ending the HIV epidemic, actually doing it with the toolkit we have now?
I think we got to do our best. I think we should, and
we owe it to the public at large, to the people who would get HIV if we didn't do it, if we didn't actually implement this toolkit. But what's missing? Like what's
now we have to figure out how to do it. We got to do it better this time, right?
Now you're the head of Office of AIDS, or the what is the deputy director of the Office of AIDS?
I'm the director of the Office of AIDS Research. Yeah.
Director. So now tell me about that. What is that?
So our office coordinates all of the HIV/AIDS research across the entire NIH, meaning we get our allocation from Congress, and we identify within our strategic plan where the funds are most appropriate to go based on the highest priority.
Okay, so this is not a theoretical question about what's missing. What should we do next? This is your job, is to help me understand, help the public understand, where should we put our resource. Now, because it seems to me, let's put it on the thing that actually ends the epidemic, right?
Yes.
So how do we do that? How are you thinking about this?
I think what we want to do is ramp up implementation science. And I didn't mention earlier, but I founded and directed a Center for Implementation Science back at the University of Illinois because I had been developing and testing all these interventions, but when funding runs out, then they sit on a shelf and we aren't figuring out how to sustain that, right? So now is our opportunity to look at how are we going to get these tools to the people who most need them? How are we going to give them the choice that they need?
Right.
So if we can put an array of options in front of them and say which one's going to work for you and why, and it may differ by population, right? It may be different for Black women than it is for gay men, but that's what we have to understand. It may be different in the South than it is in the East of the United States.
It's a very local science in the sense, right? You have to understand the needs of the local population. You have to work with public health who understand their communities much better than we might up here.
And we have to work with communities. They know what they need. and we have to work with healthcare providers, because in many cases, healthcare providers are not necessarily trained to ask questions that might be sensitive around drug use or sexual risk taking. And these are opportunities for us to focus on the broader systems so that we can improve uptake, that they can improve their processes for getting their patients or their people on board. We have to work with communities who have their hands on the pulse of what they need, and they can tell us, this is what we need and this is how you need to do it.
It's funny because, like you mentioned earlier about the NIH, like the DNA of the NIH is basic biomedical research, lab work, but this is a science too. Like there's analytics, there's tracking data, there's like trying to understand essentially populations of risk. There's epidemiology involved. There's all kinds of scientific disciplines in order to do what you're suggesting we do.
One of the ways I sometimes think about it, which I wonder what you think about this, is there's sort of the tension between internal validity and external validity, right? Internal validity is, I think, the more traditional gold standard, where you just control every single thing about a research experiment, so you are 100% confident that that result is exactly from that, because you've controlled everything. But in the real world, we can't control everything. So sometimes you have to sacrifice a little bit of that to say, but how is it going to matter, and how's it going to work here? Because this is the context that people are living in. They have comorbidities. So like if you're going to do a study on cardiovascular disease and you're going to exclude everyone who has diabetes and obesity, it's not going to...
Yeah, it works in your study, but it doesn't work in the real world.
Exactly.
Implementation science is about how to make things work in the real world.
Exactly.
And that's what we need here, isn't it?
That's what I believe. I will say, I think we continue to need discovery. Like one of the things we've talked about is these drugs are all used for the same thing, right? Prevention and treatment. So if it doesn't work for prevention, it's not going to work for treatment. And we're seeing a little bit of viral resistance right now.
So we still need to do some basic science.
So we still need to do basic science. We still need, therapeutics. We still need to understand that. But I would agree that we have tools, and our responsibility is to the people right now who could benefit from those. And we aren't reaching everyone. That's a big key piece of implementation science. Why aren't we reaching everyone? What are we missing? So we can increase reach, we can increase adoption of these, we can get, people to come or we go to them. That's a big one. We can sustain. These are all research questions. Like you said, it's a science. It's not, it's not the same.
It doesn't sound, if you're just used to doing work with labs, it doesn't sound, but it is scientific. There's rigor in understanding the populations who are at risk, rigor in understanding the constraints to prevent them from taking advantage of these amazing new technological advances that we have. But if we do it right, let me just put this in the form of a question. Can we actually achieve the goal of ending the HIV epidemic by the end of this decade?
I hope so. I'm shooting for
yes.
it. I think
actually
we can.
I think we can
but
too.
I think I'm the other part of me is like, should I promise that?
Jerry. It's not. It's a question of commitment, right? It's like
Right.
when President Kennedy said we're going to reach the moon in a decade.
And yeah,
You had to start somewhere.
Right?
And because he knew the technological tools were there, just needed to organize a research program, if you will,
Exactly.
an implementation program, if you will, to actually achieve the goal, which seemed unachievable. That's what it feels like to me right now. Right? We have the technological tools we need. What we need is an organization and the implementation of it in a way so that we can actually move our society to achieve this thing which now seems unimaginable, but is actually possible.
I think our partnerships with the other federal agencies are critical to this, and the CDC, they're the implementers. So we do the science and we say, oh, this really works. This is evidence-based. This is the best, implementation strategy you can use. And then we ask them to do it because it's not our place to do the care or the treatment. And so if as long as we continued to work, and we worked beautifully across the federal agencies for the first and the epidemic initiative, and I think we can definitely accomplish that.
Well, thank you, Geri, for spending your time with me, and let's work together. I'm really looking forward to let's we can look back and say we really did this. We actually launched the program that ended the epidemic.
When I took this job last October, I said I want to be in the room when it happens.
Yeah. All right. Well, thank you so much, Geri.
Thank you so much.
Thank you for joining me on the director's desk. To our listeners, thank you for tuning in. Drop your comments in the chat as to what subjects we should cover. Please be sure to hit that like button and subscribe button for your preferred podcast platforms. Until next time, I'm Dr. J. Bhattacharya, and this has been the Director's Desk.